And go ahead, Tim.
Sure. Well, good morning. I'm Tim Sheehy, president of the Metropolitan Milwaukee Association of Commerce, and welcome to a special edition of the Business of Greater Milwaukee. BGM webinars put a spotlight on the challenges and opportunities we face in sustaining and growing the region's prosperity. These insights are designed to help you help your business and inspire you to help shape the region's future. We're again grateful this morning to have the time and thoughtful insights from Dr. John Raymond, president of the Medical College of Wisconsin, and Dr. Ben Weston, associate professor in the Department of Emergency Medicine and the newly named Milwaukee County Chief Health Policy Advisor. So given the overflow of questions from our last webinar, we're going to jump right in with both of our guests and invite you to submit questions as well, so we can answer as many as we can over the next 45 minutes. So again, Dr. Raymond, Dr. Weston, thank you so much for joining us. And I'm just going to start in with a couple questions as we get kind of questions from the audience as we go along here. And it seems to be a current question out there, but if you've had COVID, why is vaccination a necessary step? Yeah, Chris, Dr. Weston's got a mute on again.
There we go. I'm happy to start on that one. So when we see what's often called natural immunity, or certainly when you get after you get infected, basically, some people seem to have quite good immunity, but others don't. And the problem is that it's quite inconsistent who has good immunity and who doesn't. Now, the natural question that often comes next is, well, what if I got tested and I have antibodies? Isn't that good enough? Doesn't that show that I'm immune? And unfortunately, or fortunately, as the case may be, the immune system is a lot more than just antibodies. There's T cells, there's B cells, there's all these different aspects of our immune system that works together, and antibodies is just one part of that. And the studies show that when we look at people who've been infected with COVID, it's inconsistent whether they have the full spectrum of immune response or just a smaller part. And so the vaccine is really critical, even for people who've been infected in the past. And the good news for people who've been infected in the past is when you get the vaccine, it looks like you actually have stronger immunity than people who've never been infected in the past. So it's almost an added incentive to get the vaccine if you've had the infection, because you can get extra durable, extra strong immunity.
And Dr. Raymond, you and I talked about this, the mRNA. Also, you described it as attacking the virus in a different way than your natural immunity would.
Yeah, it does. Thank you, Tim. Basically, what the vaccines allow your immune system to do is focus in on the spike protein, which is what the virus uses to attack our cells. And so you have a stronger immunity to the part of the virus that actually matters, rather than sort of a low level of immunity to different parts of the virus that may not be as important to how it works. And I want to amplify a little bit about what Dr. Weston said. You can measure neutralizing antibodies, and when you get the vaccine, you have a much higher level of neutralizing antibodies. And you also have higher levels of what we call B cells, and their memory is, those are the factories for the antibodies. And then finally, there is a surveillance part of your immune system that looks for evidence of another infection. And these are generally run by T cells. And the T cell memory that you get from vaccination is much stronger and much more robust and durable than what you would get from an infection. And just to put this in real world context, when we were having the huge surge in South America early this year and late last year, many of the people that were incredibly sick had been infected before. So there were numerous breakthrough infections, and they had not at that point had vaccinations for anybody. So we know that people are actually faring better when they get vaccinated than when they had a previous infection from real world experience.
And we also talked earlier about the Chinese vaccination being based off of a different base and being less effective.
Yeah, Tim. And again, this is sort of soft or supporting evidence, But the two major Chinese vaccines that have been distributed in the world by Sinovac and Sinopharm use a very old technology. Basically, they grow the virus and then they kill it and inject that into people to generate an immune response. So that is the entire virus being exposed like you would have in an infection. So that's very close to what people would call natural immunity. Those vaccines aren't very effective compared to the mRNA vaccines, which again focus primarily on the spike protein. So that's pretty good evidence to support in a real world setting that if you give the whole virus, it just doesn't give you the same strength of immune response as if you target that spike protein.
Dr. Weston, a question coming in here. Are there studies available that back up the claims about vaccine being better than natural immunity?
Yeah, there's quite a few studies actually. I'm happy to put in the comments. I'm not sure if it goes to everyone, but I'll put in the comments and we can distribute a link to a couple of studies. Or a link, actually, there's a CDC website I just saw here dedicated to it that references a number of studies as well. So I'll put that up there.
Great, very helpful. Another discussion I heard yesterday about the difference between the mRNA vaccinations and the if you get it naturally, COVID, and that the mRNA is better protecting you internally, and if you got COVID naturally, that you're better protected from spreading it because of a nasal or oral immunity. And I'm not even sure I'm communicating that correctly, but either you want to comment on that?
And I'm not sure if we can find a link to this, but there is an immune system in your nose and mouth, and it's different than the one that we have that's circulating in our blood and our lymphatic system. And there's strong evidence that the vaccines give you much more robust immunity in your mouth and nose than a previous infection.
Okay. Is the booster shot composition exactly the same as the prior two shots? And is there any harm in getting the booster a bit early?
The composition of the mRNA vaccines has not changed. Now, in the future, depending on what happens with the emergence of new variants, they may change the antigen or the piece of the spike protein that is targeted, just like we do every year for the seasonal influenza vaccine. That isn't anything new, but it has not changed in any way, shape, or form. Just in terms of, is there any advantage to getting it early? I would say we probably don't know. Let's follow the CDC recommendations, which for people with cancer and other immune deficiencies, they can get a third shot. It's generally recommended that happens six to 8 months out after completing the second shot. And that really is specific to people regenerating their immune system. It looks like on September 20th, everybody is going to be eligible to get call it a booster or a third shot. But starting 8 months out from completing your previous vaccination course. And that means, for practical purposes, you're really talking about people that have worked or live in nursing homes or frontline healthcare providers who completed their vaccine course in January. So they'll be eligible at the end of September. And I think there's good data based in it from Israel and now from the US that people that completed their vaccine course earlier are more likely to have a breakthrough infection. And that's the reason why they said 8 months. It looks like that's sort of a critical inflection point. But I want to make sure that everyone knows the vaccines, even though their immune strength kind of diminishes after the 4 to 8 month period of time, still gives you great protection from the things that matter. You're not going to be as sick, you're less likely to be hospitalized, and you have greater than 99% protection from death. I think the concern, though, is as we go farther out over time, that some of those protective effects won't be as strong as they are now. And that's why they're recommending getting it 8 months out.
Dr. Weston, what makes the Delta variant different from the original COVID strain?
So on a structural level, what makes it different is there's some mutations. So basically every time the virus replicates itself, which is thousands and thousands and thousands of times every time it goes from person to person. There's some mutations. Some things change slightly. Most of those mutations make no difference at all. Sometimes it makes the virus a little bit weaker, but every once in a while, a mutation happens that makes the virus stronger. It might replicate better. It might attach to your cells better. And stronger for the virus is obviously worse for us. And if there's it's a survival of the fittest. And so if there's a virus that becomes stronger, that virus is going to take off. That variant is going to take off. And that's what we saw in the Delta strain. So it has a mutation that allows it to be more transmissible, to infect better. Now that's structurally what changed, but as far as a public health standpoint, what changed, and even an individual health standpoint, is it's much more transmissible. So whereas previously the conventional strain that we had a year ago, one person might on average spread that to maybe 2 people, the 2-3 people, the new strain, the Delta strain, you might spread to 8 people. And so you can imagine how much quicker that variant spreads, how much more dangerous it is in a community because of that. And there are some studies certainly showing that the Delta variant may be more severe as well. So on a personal standpoint, that's the difference. It's more transmissible, more contagious, and then more severe, more likely to land you in the hospital.
Question here, how many fully vaccinated people have been hospitalized, and how many fully vaccinated people have died from COVID, if any?
It's a great question. So when we look at national, so there's 2 good ways to look at this. One is looking at national numbers, just because you have a large data set, or state numbers for that matter. And the other is looking at studies that are done. So some health systems track everybody they see and see what percentage of those are getting infected, what percentage of those are getting hospitalized, what percentage of those are dying. And the promising news is that the numbers all pretty much agree. So we have a pretty good sense of this. And what it shows is that typically 95% or more of the people that are hospitalized with COVID are unvaccinated. And similarly, 95%, even a little higher or more of the people that are dying with COVID are unvaccinated. So it just shows how protective the vaccine is. Most studies, and what the CDC is citing from all these different studies, is the vaccine makes you 3 times less likely to get infected with COVID, 8 times less likely to get symptoms from that infection, and 25 times or more less likely to get hospitalized or to die from COVID.
Yeah. So another question here, if vaccinated individuals can get and transmit COVID, why are we seeing policies where individuals have to prove either they are vaccinated or have a current negative test? Seems to me that being vaccinated doesn't really help to prevent the spread. So why wouldn't everyone just have to show a negative test if vaccinated or not? Summerfest and other events are making this their policy.
Tim, that's actually a very sophisticated question. I'll start by saying right now we don't have readily available tests with a rapid turnaround time to make it practical for people, everybody to be able to show that they've had a negative test within whatever the window is, 24 to 72 hours beforehand. And then the other, I want to get back to what Dr. Weston said, and we shouldn't lose sight of this. The vaccines still significantly reduce your risk of getting infected or transmitting it to other people. It's just not as good as we had hoped for, and certainly not as good as it was for the other strains earlier on. So it is perfectly reasonable to ask for either the current test result or a vaccination card to significantly reduce the risk. But this gets back to all these mitigation measures are better when they're used in combination. So people should still be thinking about wearing a mask if they're in crowded space, even outdoors, for prolonged periods of time, and trying to maintain distance as much as they can, because that gives you and people around you an added layer of protection.
Okay.
If I can add one point, I think I agree 100%. The one point I might add is I think there is this misconception that vaccinated, because there was a headline, I think it was in the New York Times, and maybe the wording wasn't perfect, and I think it was vaccinated people spread just as much as unvaccinated, and it's not quite true. So the truth to that is that they found that vaccinated people carry when they get breakthrough infections, carry high amounts of viral load in their mouth and nose. The vaccine does a great job of preventing it from getting down to your lungs, where it causes a lot of problem. But you do, in a lot of cases, have that in your mouth and nose where you can breathe it out and you can still spread to others. The important difference is, as Dr. Raymond mentioned, in the first place, you're far less likely to get infected and have that viral load in your mouth and your nose. And even if you do, studies are showing that you have it for a much shorter time period. So you're infectious for just a few days, as opposed to perhaps a week or more in people who are unvaccinated. So pretty big differences in how easy it is to transmit when you're vaccinated versus unvaccinated.
Mm-hmm. So another question along those lines, if you're vaccinated, is there a greater risk of transmission from another vaccinated person than an unvaccinated person? So I'll let you answer that question first, and then there's a follow-on one.
Tim, I'm not sure I completely understand the question, but I'll go back to what Dr. Weston has said here a couple of times. If you are vaccinated, you are less likely to get a breakthrough infection than a vaccinated person, an unvaccinated person. And if infected, your window to infect other people is much shorter, so you're less likely to give it to people around you. So if you start thinking about crowds, you want to know what percentage or how many of the people are vaccinated versus unvaccinated before you can really do your risk assessment.
Yeah, good, got it. So we've talked about this a little before, Dr. Raymond. What are the key points on how science has evolved as we learn more about COVID? I mean, I often hear in my discussions, you're moving the goalpost. And as you've said often to me, no, the virus is moving the goalposts. So either Dr. Weston or Dr. Raymond, what are some of the key points on how science has evolved as we've learned more about COVID?
Well, let me just start by saying science is an iterative process. We generate hypotheses based on what we know, and then we test them. And so it's not unusual for us to refine our understanding of a virus. I also want to point out the situation isn't static, that COVID-19 mutates and these new variants develop, it reinvents itself. And as you said, the virus itself is moving the goalpost, and that we have to be flexible and nimble and always challenge what we think we know about COVID-19. So, the whole idea that we had 8 weeks ago that we were ready to declare victory was wrong, and that we should not continue to prematurely declare victory. And I think that's been a problem for us, because we assume that we know everything that we need to know about the virus, when in fact the virus keeps changing.
Dr. Weston, is there a big difference now in the efficacy of the Moderna vaccine versus Pfizer? I mean, I read about the percentage differences in the coverage. Is that a big issue going forward? Or does it say that if you've got one, you should get a booster shot earlier than the other?
Pfizer and Moderna have always been very similar vaccines. They're very similar in their efficacy, which is extremely good. They're very similar in their safety profile, which is incredibly good. I mean, to be honest, it's hard to, I was talking to my wife about this last night. It's hard to imagine the development of a better vaccine, frankly, close to 100% efficacy, and so incredibly safe, given to 200 million people. So over time, I think the vaccines are probably aging, if you will, very similarly. Now they have different studies that come out, a study about Pfizer, a study about Moderna. You may see a % difference here and there, but I think they're very similar vaccines, and I think their efficacy and their effectiveness in the population is going to continue to be very similar.
Ben, I think probably the questioner was focusing in on a study from Mayo Clinic, where within their health system they compared the durability of Pfizer and Moderna. And there seemed to be a pretty significant difference that favored Moderna. But Dr. Fauci, who has access to a much broader swath of data, basically said, at least in his opinion, for what we know right now, what you said, Ben, is true, that they seem to be aging about the same way. And they're both very, very good vaccines.
Mm-hmm. With schools starting to open this week in MPS and in the next couple of weeks coming up for other schools, what do we know now about vaccinations of younger people, and how necessary that is, and how that helps contain the spread?
Well, I think we've seen down to the age of 12, we've seen the vaccine is extremely safe and extremely effective. I think I hope that in the next month and a half, we'll hear a lot more about down to age 5, and then we'll continue to work down probably to 2, and then probably to about 6 months in the future after that. But we certainly know down to age 12, the vaccines are very safe and very effective. As far as for parents out there who are wondering, should I get my 13-year-old vaccinated? I'll tell you, my opinion is absolutely yes. Now, last year, we didn't see a lot of spread in schools. We didn't see a lot of quarantines. Now, the Delta variant is different. We talked about that. It's spreading quite a bit more. We are seeing many more pediatric hospitalizations in this country than we saw back at the peak of COVID nationally back in January. We're quite a bit higher in hospitalizations than we were then. And so I think that tells us that the Delta variant affects kids differently. We've also, Dr. Raymond talked about the science evolving. We've also learned a lot about long COVID in children. Now, the studies still vary. Anywhere from 4% up to 24% of kids seem to get long COVID type symptoms, these long lasting symptoms, whether it's fatigue, trouble concentrating, trouble breathing. But even if you go on the low end, 4%, that's one kid in every classroom that has a full outbreak that might have long-term symptoms. So I think the answer to me is fairly clear that if you have a child who's eligible for the vaccine, I certainly would pursue getting them vaccinated.
So as we look at the current situation, and I know it's always hard to look ahead with this, what steps can employers take to keep their work environments safer?
Well, maybe I'll start, Tim. This is so hard because I think each sector of the economy and each business has its own issues to deal with, just in terms of how it interacts with its employees and the general public. But some simple things: encouraging vaccination, sharing the best information possible. And we recognize there's a lot of skepticism out there, and that the issue has become politicized. Talking about the overwhelming evidence that supports some of these other mitigation measures. And I know it's amazing, 17 months into the pandemic, people still don't believe masks work, and you can find a study or two to support that. But if you look at the totality of the literature and the science, it's very clear these are effective intervention measures when multiple people wear masks and they wear them properly. And probably thinking about when if you have people that are working remotely, when to start bringing them back in phases. So at MCW, we were, like many employers, going to start our return to on-site work plan in phases on September 7th, right after Labor Day. And we've pushed that back to November 1. And, we may even have to push it back a little bit further.
Dr. Weston, as you look at your health policy advising role for the county, we've seen, Chicago, I think, and some other places reinstitute a mask mandate. And I know the Common Council is coming back in September to think about that. What are your thoughts on that, both from a health perspective and then from the perspective of just, how people might react to that, and whether a mandate's going to be helpful in this environment, or whether we encourage people to do it in their business or voluntarily on their own?
Sure. Well, certainly it's important to note that Milwaukee County is not its own health department. We have 11 different health departments in the municipalities. Now, more specific to your question, we know that there are layers of protection that work. We know that the vaccines are probably the strongest layer of protection that you have, but masks are another one, distancing is another one, ventilation or being outdoors in open air is another one. And so I think municipalities, as well as businesses and schools and governments and every institution, needs to consider, how can you combine those different layers of protection in a way that keeps the economy going, keeps education going, keeps businesses going, but still keeps people safe.
Good. I'm going to encourage you to ask questions if you've got them out there. We've got two great experts here, and so don't hold back on the questions. Another one for both of you. What are we learning from other countries in their approach to dealing with the spread that might be helpful here in the U.S.?
Well, Tim, let me start again by saying we do need to learn from other countries that are maybe a little bit farther along in terms of the progression of the pandemic or their mitigation measures, but we shouldn't prematurely declare victory. I want to say all the chatter about Sweden that we have listened to now for a year and a half, and their economy is no better, it's maybe worse than other Nordic countries, and they have not achieved herd immunity. So they're sort of more relaxed approach, which people were touting as superior, really wasn't. On the other hand, things like vaccination, we can learn lessons. So I think all of us look at Israel, and Israel was one of the first countries to get over 50% vaccination rate. They're a little over 60 now, and they had Delta start to circulate about 2 months before it circulated here. And what we saw is what we're seeing now, that although things looked great when Delta wasn't there, there were more breakthrough infections and some increased hospitalizations, spread in schools, teachers were getting sick, even if they were fully vaccinated. And we're seeing the same thing here. So Israel is, it's an advanced country like we are, with great healthcare system, good science, and they're a few months ahead of us. But I would encourage people to look at our own states. What's happening in the Southeast in particular right now, what happened in Missouri and Arkansas, they're a month or two ahead of us. And if we don't do things differently, we shouldn't expect a different outcome. And one of the things that struck me, my wife actually showed me this in the New York Times, was ICU utilization is very, very high in the Southeast. But over the last week, there's been a march right up the middle of the country, up through Minnesota, with a significant surge in ICU utilization. And that's probably going to happen here unless more people get vaccinated and people take these mitigation measures more seriously. And we know there's a large portion of our population that simply don't want to or don't believe in the utility of wearing masks. And I think those are things that if we don't change and we don't do things differently, we're going to have a pretty significant surge here in Wisconsin as well over the next few weeks.
Dr. Weston, I know this is a difficult question, but we're so far into this and we've been discussing this so much. And as Dr. Raymond just mentioned, there seems to be this barrier, this threshold we don't seem to break through in terms of getting more people vaccinated. Any thoughts on how we can make those breakthroughs going forward? Or have we, in a sense, hit a public wall where everybody that's going to get vaccinated has been vaccinated and we're just not going to convert more people to it?
Yeah, it's a great question, an important question. I'm optimistic that we can get quite a few more people vaccinated. I think there's 3 groups that are left that are unvaccinated. And I know there's lots of different studies and organizations that break them down, but the way I think of it is there is a population that just refuses to get vaccinated. But that population is relatively small. It seems to be about 10 to 12% in most studies. But then there's the rest of the population that's unvaccinated. I think they fall into one of 2 camps. I think one, and they overlap quite a bit. And I think one is people who still have questions. I'll tell you, I work in the emergency department as well, and I talk to every patient about the vaccine. And I'd say at least 2 out of 3 who are unvaccinated just have some questions. Does it really make you sick? Does it really change your DNA? Am I going to feel like myself after I get the vaccine? Relatively straightforward questions that they just want heard and answered. And when those questions are answered and they have a better understanding of the vaccine, I think they feel a lot more comfortable about it. Now, the other group are groups with barriers, and these tend to be our more vulnerable groups. Now, there's a lot of overlap of those 2 circles, the questions and the vulnerability. But you can imagine if you are a single mother with 3 kids and you work 2 jobs and you don't have a car and Sunday's your only day off. And if you want to get vaccinated, you're going to get on the bus with those 3 kids and take them across town to a vaccine site. And oh, by the way, every time you log on Facebook, you're seeing ads about how the vaccine does this terrible thing and does this terrible thing. I don't know that your motivation is there to haul those 3 kids on the bus and drive across town. And so I think that's where continued messaging, continued education, and then breaking down those barriers, making the vaccine available where that person is, whether it's at the grocery store, whether it's at state fair, wherever it is.
Yeah, a couple of really good questions that I know you've gotten before about the differences in the types of masks that people should be wearing. And is there a big difference between, the surgical mask that we see people wear or handed out when you walk into a store and the more sophisticated N95 masks? So how would you respond to that? Are they varying levels of protection, or is one just not effective and you'd encourage everybody to get an N95?
Tim, it's such a great question. And we've actually had a pretty significant internal conversation here at MCW about the quality of masks that people are wearing. Let me start by saying masks work. They work best when more people wear them and when they're worn properly. And if you have a lot of people wearing masks and they're covering the nose, mouth, chin, and both cheeks, and it's snug on the bridge of the nose, you're going to have great protection, whether that's a cloth mask or a paper surgical mask or an N95 mask. Clearly, though, an N95 mask has more favorable filtration properties, and it's going to give you a little bit more protection, but it's also uncomfortable. And so you're compromising about the risk and benefit of masks. What I would say at MCW, we've seen a lot of people with droopy cloth face masks that don't necessarily cover their nose like they should. And even if they cover the nostrils, they're not very snug up here on the bridge of the nose. So we're going to recommend that people upgrade to surgical masks in the non-clinical environment. And even in the clinical environment, there are only certain settings in which people are required to wear the N95 mask. So I don't think anyone right now is recommending that in the general public that you should necessarily have to wear an N95. If you want to, make sure it has no vents. It needs to be a mask that isn't vented, because you're actually concentrating your respiratory droplets and then expelling them to everybody else. But yeah, you don't need to wear an N95 in most situations. And, Ben, I don't know, you may think differently about this.
No, I agree completely. I think I would echo that. I think the most important thing about a mask is really the fit. You can wear an N95 mask below your nose, it does nothing. You can wear a surgical mask that's loose, it does pretty much nothing. And you can wear a cloth mask that fits really nicely and it does a whole lot. I'll tell you personally, I tend to wear a surgical mask when I go out in public. If I'm going to the grocery store, if I have to run into wherever, when I'm in the emergency department, I switch between surgical and N95 because I'm in a higher risk environment. But typically I think a surgical mask that's properly fit, you have to have that stiff part that goes around the nose and kind of pinch it down, is going to be a pretty good bet in most circumstances. And you can get also, if you want a higher level of protection, you can get KN95s are readily available. But again, I'll tell you, I bought some KN95s the other day. I tried it on. It wasn't a very good fit. I felt like air was leaking. I went back to my surgical mask because I think it's a better fit and therefore a better mask for me.
Maybe Dr. Weston to start, and then Dr. Raymond, just looking at the trends for Metro Milwaukee and Wisconsin today, and kind of what we've seen in terms of the peaking and, double-digit deaths today, I think, and a little higher use of ICU units. As you project out based on what we've seen, and I know this is another difficult question, what do you see in terms of at least this current wave as we look out over the next couple of weeks, the end of summer, as it were, and the return to work in September for those that are coming back? What do you see in terms of the trends?
It's a complicated question. And the short answer is nobody knows. The longer answer is I think we can use some evidence to predict some trends. So on the promising side, we see in places like the UK and Israel that Delta goes up quick and comes down relatively quick. Now, relatively quick still means a few months, but not, a year or anything like that. Now, the United States is very different from the UK and Israel. We're much larger. We have a very diverse population. We have very diverse regions with different levels of vaccination and different levels of, compliance with mitigation measures like masking. Now, the other things to consider is when we look at Milwaukee County and at Wisconsin, it looks like our cases are starting to level a little bit, maybe even starting to come down, which I think we all hope that they continue to just plummet and go down, and they'll be followed by hospitalizations going down, and that will be followed by deaths going down. But we are in a little bit of a tenuous period. We have back to school that came for some communities, is coming for others. We have cooler weather coming, not to say this is a seasonal virus, but to say with cooler weather, more people gather indoors, and we know the virus spreads more easily that way. So I think it's very hard to predict. I think we can be very, very cautiously, with an emphasis on caution, but cautiously optimistic that hopefully we're seeing some leveling off. Although I'll be honest, when you look at the national trends, there's not really leveling off. So I'd be pretty cautious with any predictions there.
Yeah, Ben, if I could, I'm less optimistic. We've always seen shoulders and then another surge, and that's just part of the epidemiology of this virus. And again, I'd say let's look at what happened in other states. And there have been slowdowns, but then surges again in Missouri and Arkansas, Florida, Texas, Louisiana, Alabama. So even though we all want to look for signs of hope and optimism, again, I'll get back to, if we're not more vaccinated than these other states, if people aren't protecting themselves to a different degree with mitigation measures than the other states, we probably shouldn't expect to have a different outcome. And so, I'm looking at the WHA data. The hospitalizations are going up at a fairly significant rate, and so is ICU utilization. And what's different now than in November, when we pretty much reached about 95% capacity in our ICUs at one point, is we have a lot of pent-up demand for non-COVID business, and our hospitals are pretty full right now. With cancer patients and cardiovascular and neuroscience patients. And I'm looking at the ICU use, and we have 1,359 beds in Wisconsin, and only 121 of those are available. So we're 92% full right now, and we're still on the upsurge. So I'll go back to what Ben started with. Nobody knows. We're all kind of looking into a cloudy crystal ball right now.
Yeah, so I'm going to ask you another difficult question here, both of you, and I'll pick on myself. If there's anybody in the community that gets invited to more lunches, dinners, outings, running the Chamber of Commerce, that's one of the hazards of the business, I guess. And so, I look ahead at the Brewers, hopefully, knock on wood, making a playoff run where you're going to have tailgating, packed crowds. We had the night market last night. I see large functions, and not picking on them, like the Business Journal. You've got 400 people for a luncheon. There's another one coming up with the CEO of Exact Sciences. I was at a dinner the other night, 40 people in a restaurant. I just don't see kind of the social distancing and the masking, lots of people vaccinated. So as you kind of look at that going forward, it sounds like to me, the message is to get vaccinated, because those that are vaccinated, I think, feel some protection and are engaging in the normal course of business much more than we were when we first came into COVID. So what are your thoughts going forward there, just from a practical standpoint? I don't see the mass pullback that we did earlier when COVID hit us, and I don't see the appetite for mandates in the community.
Well, I can start. I think, to me, this comes back to considering layers of protection. So I'll tell you what I do. If there's a lunch I'm invited to or something like that, now I'm probably a little more cautious than some, but I think about layers of protection. And if I can sit outdoors, I want to sit outdoors. If I can be in a less crowded environment, I want to be in a less crowded environment. Of course, I'm vaccinated, but I know that the Delta variant is different. It's different than back in, when was it? June, July, when our cases were low, and the Delta variant was also very low in our community. At that point, I felt a little more comfortable having my vaccine give me strong protection in, settings around other people, even indoors. But times have changed, unfortunately, and the virus changed its mind and is doing something different. And so I think for the time being, with the Delta variant the way it is, as transmissible it is as it is, and as severe as it is, we have to consider layers of protection. And that's what I do. So I try to think, can I wear a mask? Can I distance? And can I be in open air, knowing that I'm vaccinated? And if I can do all those things, I feel very comfortable with it. If I can't, I think twice about whether it's something I want to participate in.
Yeah, I think that's fair. And just in terms of doing a risk assessment, one of the things we probably don't talk about enough is paying attention to what's happening in your community. If it were June and early July, when the case burdens were in the single digits, the chance that you will either get or spread COVID-19 to somebody else is pretty low, because you're not going to have that sort of incidental contact that has a high risk of transmission. Now with a surge, and we are at a very high level in Milwaukee, and the trajectory is unfavorable in most of the counties of our state, that incidental risk goes up. And so you should be a little bit more careful when the burden of disease in your community is high and going in the wrong direction.
Yeah. In the couple of minutes we have left here, and I'm going to ask you both a question. Dr. Raymond, you've been doing this a little bit longer than Dr. Weston, but I don't know that I've ever seen a public issue as divisive as COVID has been. And both of you have been fact forward, I would say non-emotional in answering questions that we've had over the course of the year. But you can clearly see, as I've done this, the hostility in the questions, the anger in the questions. And I kind of want to get you both to respond to kind of how you think about this going forward in just addressing what is, again, an incredibly divisive issue that's going to be with us for some period of time.
Well, maybe
Sure.
Why don't we let Ben start, because he is more than I am a frontline healthcare provider, although I am going to be taking care of patients at the VA starting tomorrow. How are people feeling now? We're 18 months in, we're doing our best, and there is hostility and there's frustration about people not really understanding or embracing the science.
I mean, I'll say from a healthcare provider perspective and talking to my colleagues, I mean, you can't get around it. There is frustration. I think there's frustration that what we're seeing now, the cases, the hospitalizations, and the deaths at this point are preventable. That wasn't the case necessarily a year ago. But at this point, we have one of the most effective, safest vaccines that's frankly ever been developed in history. And so a lot of what we're seeing here is preventable. But that said, I think that, there's a great book, I think it's out of print, it's hard to find, but it's called The Healthiest City. And it's all about the history of public health in Milwaukee. And going back to the, early 20th century, when there with the pandemic, there was controversy. There were people who didn't want to wear masks. There were people who didn't want to, have to stay in their homes. And it's repeated itself. Now, obviously, we're in a more politicized environment than in the past, but I think it's not necessarily expected. But what I try to do, I know what Dr. Raymond tries to do, is just lean on the evidence. And there's more and more evidence that comes out every day. We're getting a better and better understanding about this virus. There's still a lot we don't know. But I think just leaning on the evidence, going to evidence-based sources, whether you want to go and read the CDC website, or if you want to go and talk to your personal doctor. You've trusted, I think, your personal doctor to put you on a blood pressure medicine. You've trusted them to decide what cholesterol medicine you should be on, to advise your diet. You go on all these different medicines that frankly have far higher side effects and a far higher risk profile than this vaccine. But you trust your doctor for that. And so I would say talk to your doctor and trust your doctor on this as well. And I think it's very meaningful that, and this is a number from March, I haven't seen updates, but I'm sure it's a lot higher, but more than 95% of physicians have themselves chosen to get the vaccine and get it for their families. And I think that's pretty telling. Yeah,
Ben, you said it really well. I think what's frustrating for me is the erosion of trust in healthcare providers. For the most part, we're all here trying to do our very best to take care of our patients and our communities. And I think most of us try to not take it personally when there's hostility, because this is a difficult situation, and American culture, we're problem solvers, and we expect to find solutions. And so far, this virus has stayed 1 or 2 steps ahead of us, either because of what it's doing to change its biology, or what we're not doing to try to put our best foot forward as a society. And that is frustrating.
Well, again, I want to thank you both. Dr. Weston, you're probably too young to get this analogy, but I'm thinking Dr. Raymond well. So in the words of Jack Webb from Dragnet, thank you for just the facts, ma'am. And appreciate you both coming on, answering the questions, and look forward in the future to getting you back here, because I think, again, it's a free country. People can make their decisions. You're just trying to give us the best facts to make those decisions, and we're very appreciative of it. So thank you all, and thank you very much for joining us, Dr. John Raymond and Dr. Ben Weston.
Thanks, Tim.